So next is Dr. David Landsberg, who's the transplant nephrologist here, and he's actually the medical lead now at BC Transplant. So we welcome Dr. Landsberg. Thank you.
Good morning, everyone. Great to be here. Story of my life. Bill is quiet and unassuming until he gets up in front of the audience, and then he blows you away. That's what he does with patients. And so I see a patient before the transplant. I tell him all the bad stuff. Bill, the hero, comes in, that does his magic in the OR, and then I deal with the patient I'm not deal with the patient for the rest of their lives. And whenever there's a Christmas present or some acknowledgement of what a wonderful job we do, it's all the surgeon. Whenever there's a problem, whenever there's an issue, even if it's, my incision is killing me, I got this thing sticking out of my side, it's my problem. So what I'm saying is it's difficult to follow Bill, and he's very, very modest. Closing on 1,000, right? Transplants you've done or gone beyond that. Way beyond. So Bill's like he still looks like he's 12, but he's done well past 1,000 transplants. How many donors? Yeah, donor operations, like 800 or 900 donor surgeries. So the reason that I'm focusing on this isn't just because Bill's a great guy, is because my goal for today is not to brainwash, but to use, I think, facts and experience to help you feel comfortable that when you're talking to your patients about getting a living donor, when you're talking to potential living donors, that it's safe when it's done correctly, and it's a standard thing which we do. And it's the best thing for a recipient. And so for the right person, the right individual who wants to help somebody else with kidney disease, it's the best thing that they can do. I want to focus today on preemptive transplants. So that's where the kidney care clinics come into play, because you're the people who see potential recipients of transplants the soonest. And I think that we do a great job in BC in terms of our living donor numbers, but even though we do a great job, I really believe that we can do significantly better. And in particular, where we can do better is by offering more of our patients preemptive living donor transplants. So that means our philosophy is a little bit of a switch. We talk about orientation to dialysis, but what I'd like to, and we talk about home therapies, home first, PD first. What I'd like to talk about to get the mindset is transplant first. And so not everybody is eligible for a transplant, and Jag is going to give us a talk this afternoon about eligibility for transplant. And so, we don't want to set expectations so high that an 85-year-old patient coming to the KCC thinks that the transplant is going to be their best option. But for the majority of people who are less than 70, 75 these days, who are otherwise in decent shape, kidney transplant is their best option. And if they can get that transplant before they have to start dialysis, that's even better. And so when you're looking about outcomes and half-lives, the best outcomes are in people who have transplants before they even hit dialysis. And Owen's going to talk to you a lot about that in a couple of moments. But what I want to focus on is the kidney donor. And so you're not going to feel comfortable talking to patients and donors unless you actually believe that a living donor transplant is safe and it is potentially the right thing for somebody to do. So I'm going to give you the facts, and the facts are not totally straightforward. And I'll acknowledge where there have been some questions asked, and I think for most of those questions asked, we have some reasonable answers. And it's not for everyone. my number one thing is donor autonomy, and making sure that a donor is free from pressure, free from coercion, is making this choice because they themselves believe that it's the right thing for them to do, it's the thing that they want to do, and it's the thing that they want to do to help somebody. Whether that person is their brother, their sister, their cousin, their husband or their wife, their friend, their coworker, and these days, their friend who they connected with, 5 years ago, or they last saw 5 years ago in high school, but they saw on their Facebook account that they now need a kidney transplant. I think, we've come into that age where social media and the way that people relate to each other is not necessarily just the way, it happened in the past. And, I think that's totally legitimate as well. So somebody where there's a connection, where you want to help them, for many people, that this is like a calling which speaks to them. And, for them, if it's safe, the right thing to do. So let's talk about how safe it is. So like Bill, I have disclosures, and I also make my living doing this. And so, so I'm going to come out with a bias, and we do things a little bit differently than many other centers in Canada, and even some U.S. centers, in that the transplant doctors, the transplant nephrologists, and the transplant surgeons see both the donors and the recipients. When I say we see both the donors and recipients, the assessment of all the donors and all the recipients is done by the transplant team. We try to separate the team, at least one individual in the team who is seeing the donor from the person who's seeing the recipient, in order to avoid that conflict of interest. But we feel strongly that, in fact, we can provide the best information to potential donors about the risks of living donation. We can give the best assessment of the safety of the procedure. We can answer the questions the best. And therefore, we're very, very conscious of this potential. If I saw your brother last week and I say, hey, you really need a kidney transplant, no, I'm seeing his brother as a donor, and I can say, well, you look pretty good. We'll sign you up for next week. So if I saw the recipient, the brother, it won't be me who's talking to his donor, but we do, still work together as a team, and we put our cards on the table with donors and recipients when we're talking about this, and we say, if you've got any concerns, if you think, well, maybe they're haven't told me everything, we'll be glad to arrange for a second opinion, for you to see somebody independent. But the reason that we're doing it is, one, we're totally upfront with that, and I believe that we can do the best job, and provide the best information to donors about the risks of the procedure. And we want it to be safe as much as everybody else, or probably not more than probably not more than everybody else, but just as much. And I say to people, the safety of our the success of our living donor transplant program relies on safety for the donor. If there's any hint that living donation is crossing a line on safety, then that's probably the end of our program. And so we are very cautious. On the other hand, if you don't take risks, you're never going to do anything. So we're all, I'm going to talk more about how you get risk, how you handle risk in your mind. And so even though I'm talking about the safety, and Bill talked about 3 in 10,000, that is still 3. And there have been donor deaths in Canada, and it's devastating. However, if you let that number, 3 in 10,000, stop you from doing living donor transplants, then that's almost 10,000 people you haven't helped. And so, in medicine, we make calculated risks all the time. So, my interest in this is, I'm the chair of the Living Donor Advisory Committee for CBS, and so my passion is living donation, and my goal is to not only get living donation to another step here, but also across the country. But I think, knowing the landscape, we're leading the way, and I really think this initiative for preemptive first is going to push that even further. So what risks are we talking about? So like Bill said, am I going to die? Is probably the donor's first question. They usually are thinking about the surgery, but what I'm thinking about is their life going to be cut short? Are they going to, we're going to have a code blue or something?
Code white, prominent 10 Charlie. Code white, prominent 10 Charlie.
That's a common one, by the way. Code white 10 Charlie, 10, yeah, I'll say no more. So could something happen to you later in life which would cause you to die prematurely because you're a kidney donor? And I'll talk about that. I think the biggest issue, the thing that we focus on the most as kidney specialists, at least the nephrologists, not so much the patients, the donors. They don't necessarily think about it like we think about it, but we think about, well, what about if you get kidney disease yourself? I mean, are we going to create kidney disease? Or are we going to put people at risk who have only one kidney of ending up with, in the worst case scenario, needing a transplant themselves or having to go on dialysis? And so that's a critical point to address. And then another question which is common, and many donors are younger women who are contemplating further children or having a family, haven't been in that position yet. Is that going to affect this? So these are the things that I think the donors need to know about, and therefore I think the things that you should know about a little bit, so you can feel more comfortable about it. So what about mortality? So in the good old days, there were, you could pick up a journal, and the title of the article would be, kidney donors live longer. And so kidney donors didn't live longer because they were bestowed by whatever your belief is, by whether it be karma or divine intervention. I don't think because you did a great thing, you necessarily got a gift and therefore were able to live longer. I think what that means is we were good at picking out who was healthy and who was most likely to live a long time. And so when you compare it to the general population who aren't screened in the way we screen kidney donors, well, of course they should live longer. So there's lots of stuff where it showed that living kidney donors live a longer time, and these are 5 studies where the top curve is always the donors and the bottom curve is the general population. But what about comparing them to people like themselves? So now it's a healthy person who's been screened and tested, and then you're comparing the donor to that person, and the donor, we would hope, would have the same life expectancy as that screened healthy person. So there were 2 studies, one from Canada, one from Ontario, where they had the ability to look at all of the donors in Ontario, and one where they looked at the whole donor network in the US, the paper that Bill mentioned by Dori Segev. And in both of those things, when you look, this is the Ontario one, you can see that compared to the healthy controls, the donors are still doing as well, if not better than the healthy people. And in the US, similar type of thing, the donors actually were as good as, if not a little bit better than the donors. This is part of this paper that shows that even though the donors did better, I mean, in general, actually, it's more about kidney function in Afro-Americans than for death. So there's maybe some differences, but donors, this is just the population in the U.S. They're not doing as well as the donors. So donors up until 2014 did great, did as well, if not better, than healthy controls. Then there came this paper in Kidney International by a group from Norway, which put some questions on that. And in the interest of you knowing all the facts, this was a study where they had almost 2,300 kidney donors, and they compared that to a healthy group of control patients who were used in a study looking at heart health. And so these were very healthy people who were served as their controls, and they said, well, the donor should be as good as them, so let's compare those two groups. And when they compared those two groups, you can see by about 15 years, it looks like there's more mortality now. These are the donors who are dying more frequently than in the recipients. And so that was, sorry, in the donors. So this is donors, these are healthy people. I don't usually talk about healthy people, that's why. But before you focus on that slide too much, there are a lot of criticisms about this. So the biggest criticism was that it was like one county in Norway, and the donors were not actually well matched up with the controls. The controls were younger than the donors. There was more smoking, believe it or not, in the donors. There were a lot of factors which would mean, independent of being a kidney donor, that they weren't actually comparable groups. So the number one thing is when you're looking at donors is you got to compare apples to apples. And so this probably wasn't an apples to apples comparison. And so there was another study about the same time done in the US where they did a very rigorous job to try and compare apples to apples and to try and get the right control group and to try and make sure that they didn't miss any events. And they focused on older people, and basically they screened an awful lot of people to come up with a whole bunch of pairs who really matched up beautifully and who could provide all of the data that they needed to track. And basically in this group of older people, these are the donors and this is the controls. The donors are living longer than the controls. So I think it's fair to say that if you go to a transplant conference and you talk to transplant people across the spectrum and you say, do you think that there's a increased risk of donors dying, not at the time of the surgery? Well, of course, we said there's 3 in 10,000 risk, but over the rest of their lifespan, is their lifespan going to be shortened by living donation? And the answer would be, probably not. There really doesn't seem to be much to lead us to believe that. Well, why would that be the case? So if you have less kidney function, and you're in CKD now, and let's say so a lot of these donors, we'll talk about their GFRs in a second, may have eGFRs, which are below 60, and if they had kidney disease with an eGFR over less than 60, they might, or they would have perhaps some risk factors for, let's say, premature atherosclerosis. And therefore they would have some more heart disease, and maybe that would shorten their life expectancy. The thing that I fight about is that I don't think having a single kidney isn't a disease. When you have kidney failure because of a process which is causing ongoing damage to the kidney, that's quite a different situation than when you've had surgical removal and you're totally healthy. So I don't think you can. And I would object strongly to classifying, a kidney donor as having a disease. So let's talk about GFR. Let's talk about kidney function. Let's talk about how people's kidneys do when they donate. And so up until 2014 again, they did great. When you compared the outcome of donors to the kidney health of a general population, the kidney health for donors in terms of the freedom from going on to dialysis or needing a transplant looked really, really good. So there was no increased risk of kidney failure identified in donors over the general population. It's important to realize that not so much in Canada, because we just don't have that many Afro-Canadians or we don't have that many Afro-Americans as potential donors, but there is a much higher risk of kidney disease and kidney failure in blacks. And certainly that's a high-risk group. In this study, when they looked at the renal failure rate, it was still, for blacks, it was black donors, it was half the rate in the general population. So donors were still doing okay, but it's a high-risk group, and we're going to talk more about that in a minute. So then the big paper that came out also in 2014, again by this Doris Segev, using the same controls group. The control group in the first study was used. This Haynes group was used to look was for death. Now this is one that's looking for a kidney disease, and basically when they were able to go back and look at all of the donors in the U.S. from 1994 to 2011, and they found 99 cases of donors ending up with kidney failure. When they compared that to their control group, they found 17 cases of kidney failure in their control group, but in fact, their control group was only 9,000 people versus almost 100,000 people in the donors. And so this led to some very complicated mathematical modeling to match healthy donors to, healthy individuals to donors multiple times. So one control could have been matched to 25 different donors. And so if that control did well, then that was going to be amplified many times when they matched it out to all of those individual people. And since kidney failure was such a rare event, it seems pretty random how they decided to match which donor with which control, and so that could certainly have led to some mathematical problems. And so they did see, though, as time went by, there was more. When you did this over time, there was more kidney disease and more kidney failure in the donors versus the non-donors. However, like I said, there were 10 times less. There were 10 times less non-donors. There were 10 times less control people, and so they just projected that out to 36 kidney failure events versus 99 kidney failure events that I showed you in those donor people, and that's just the way they matched them out. But the bottom line was, I'm going to come up now with we're going to put forward the notion that, of course, it's going to be riskier if you're a kidney donor and if you have only one kidney, you're living the rest of your life, and things can happen. Things can happen in 5 years from now, 10 years from now, 20 years from now, 30 years from now. And if you only have one kidney and something happens, you have less reserve, and it would stand to reason that you could, that in people in whom something happened to, they would have a higher risk of ending up on dialysis. But it was only, when they projected those numbers, at 15 years, it was only 3 in 1,000. So 3 in 1,000 people ended up on dialysis in donors over a 15-year time span. But I really believe that some people will develop kidney failure, actually because they were donors. And so, are you willing to accept that? Again, it's the same. It's the same as the 3 in 10,000 for death. If you're not willing to accept any risk, then it's unlikely that you're going to be able to get any benefit. And it's a matter of calculated risks. And when you talk to donors and you say, what risk are you willing to take? Donors are usually much more willing to accept a significantly greater risk than I myself would feel comfortable with. So we're going to talk more about that. So you don't get kidney failure just because you donated. You get kidney failure because you donated, and like I said, something happens. And so what's happening here is you're going along with good kidney function, and then you get a second hit. You get diabetes or you get high blood pressure. Those would be the things that I would really worry about. That diabetes and high blood pressure is leading to some kidney damage. Over time, you have half the kidney, you have half the kidney function, you have half the reserve, and you're going to end up with kidney failure more quickly with one than with two. So far, I think what I didn't focus on, but I think is clear, is like, you know, in our donor workup, we can pick up the people who are at the highest risk of developing disease in the future because they already have a risk factor. They have an abnormal lab test. They have an abnormal physical examination. They have high blood pressure already. They have an elevated fasting blood sugar already. That's pretty obvious. But there are lots of people, and the younger they are, the more so, that they look great today. But who knows in 5, 10, 15, 20, 25 years. So my philosophy about recipients donors has totally changed. So I used to think a young donor was great, but they were great because they had great kidney function. But in terms of donor safety, you know, if you're 25 and healthy, that doesn't predict out to 85 nearly as well as if you're 65 and healthy. Because the 65-year-old, all the bad stuff that could have happened over the 40 years from the 25 to 65 has already happened. And it didn't happen, that's why they're healthy. Whereas some of those 25-year-olds, despite your best effort to identify them today, there's nothing obvious, and you say you're good to go, but it's more of a gray box, or black box, I guess. Come back to that in 1 second. So what about pregnancy? Well, there is a higher risk of toxemia pregnancy, preeclampsia, you know, fluid retention, high blood pressure. The risk is about double in women who donated. However, when there's been a long-term follow-up of these women, their outcome has not been different, has been the same as other pregnant women. And so it is a risk of toxemia. I can't say it's good to get toxemia, but it doesn't seem to lead to anything obviously worse. And so, you know, I think women who are contemplating pregnancy after donation need to know that. So we had a consensus conference in Canada, which I actually chaired, where all the programs sat around and said, okay, we got to get on the same page about living kidney donors because we're doing kidney pair donation. And so that's when there's a donor-recipient pair, which we'll talk about later. The donor can't donate directly, so they're going to donate to somebody else, but that donor is going to go, let's say, to Montreal to be the donor. Well, if Montreal has a totally different acceptance criteria than we do, they arrive in Montreal and they say, oh God, I don't like that. That's not what we thought we were getting. This isn't going to work. So we needed to all be on the same page. So we developed a set of criteria which we thought everybody could live with in terms of acceptance. So where are people too high risk? Well, if they're diabetic, obviously they shouldn't be donors. Well, I say obviously some people actually do use diabetic donors, but it would stand to reason that diabetes is the leading cause of kidney disease. And if you already have overt diabetes, I think it's a bit risky to say you're good to go as a donor. So people are on a spectrum of their risk of diabetes, and certainly family history, their physical activity level, and their BMI are all determinants, but also their fasting blood sugars, their hemoglobin A1Cs, and their oral glucose tolerance tests. So as you get along the spectrum to diabetes, we define some people who are too high risk. And actually, Olin was the chair of the group who worked on that. Kidney function, there's cutoffs for kidney function. The older you are, the lower that we can go with kidney function because you don't need the kidney function to last you as long. And then looking at BMI cutoffs, which is one around just the safety of the surgery. Very overweight people have a higher surgical risk. So as far as kidney function goes, the higher the better. We want 90 for a young person. Centers actually said they would go down to 75. I didn't even feel comfortable with that. It was interesting because we were probably more aggressive on most things, but the thing that they said was that some centers were willing to accept donors who were better than 75. We would say 80. So a big issue, though, is like who gets to decide. You know, so now we've identified some risk factors, but you know, when is it too risky? If the donor says, well, I don't care, I'm willing to take that risk, you know, do you respect the donor's autonomy? Do you respect their decision if you believe that they're well informed, or do you say, well, I don't care, that's too risky for me? I think at the end of the day, Dr. Gourlay was not going to operate on somebody, regardless of what they want, if he feels it's reckless. If he feels it's the wrong thing, he's not going to do it. If I feel it's the wrong thing, it just crosses a boundary, which I said that feels too risky, then we shouldn't do it. On the other hand, I think it's very important that we hear people and we understand their perspective. And people make a lot of value judgments about when the motivation is good, when that makes a lot of sense, versus not so good. And so I try to get away from that and try to focus more on absolutes. And so I think that we have a threshold and we have an obligation to define that threshold, and hopefully we can then build up a model where we could put in risk factors and be able to be pretty accurate about what that risk is. And if that risk goes beyond our threshold, then we shouldn't do it. But if the risk is below our threshold, if we say, okay, we're willing to accept up to a 3% risk of a donor having kidney failure and ending up on dialysis, if the donor accepts that and we're willing to accept that, then does it really matter if the donor wants, is donating to a mother to the daughter or the friend on Facebook? Their risk is the same, the gift is the same. We're perhaps making, this is my own philosophy, but perhaps if we don't think the donor on Facebook is legitimate, I'm not sure I agree with that these days. So how do individuals make that decision about whether it's too risky or not? Well, they look at the risk, and hopefully the risk is up here, that we haven't loaded anything into that basket. So it's low risk, and there's a lot of stuff on the benefit side, and they say, okay, to help my brother, to help my son, to help this person, I'm willing to put myself in harm's way. I'm willing to go through that surgery, and I'm willing to take the chance that later in life I develop kidney disease because I feel that I can make this gift today. I think that risk is acceptable to me, and this is the right thing for me to do. Now, it's one thing for us to say that, it's another thing then to convey it to patients. So what I don't like to say, one person's assessment of risk is not necessarily the same as the other. This is like the classic thing where if something is very, very unlikely, and the outcome is really bad, then you say, okay, even though it's really, really unlikely, it's only medium risk. In another table, if it's improbable and catastrophic, because it was so improbable, people said it was low risk. So medium risk, low risk, what does that mean? Well, like I said, if you don't take any risk, nothing good is ever going to happen. And maybe this is too inspirational for this time of morning, but like all of us, we're willing to take some risks. It's not crazy to take risks. We put people in harm's way a lot. There are people in high-risk professions, firefighters, soldiers. There's all sorts of high-risk professions. Society in general doesn't say nobody take any risks, and so it's our job to present the risks. So things that are good, things that are not helpful are, it's safe. What does that mean? Low risk. The risk's a bit higher. Oh, it's 3 times the risk. It's 10 times the risk. Well, what's the risk? And so what's helpful, I think, is really painting the picture in black and white. And so my analogy now is the jelly beans jar. This is the jar of jelly beans. And say let's say we want to put the risk of dying. So we got 10,000 jelly beans in that jar. They're all white. And I pull 3 of the white ones out, and then I put 3 black ones in, shake it all up, and I said, are you willing to put your hand in there? And if you grab the black one, you're the one who died. and they see this huge jar of jelly beans, and they see that those black ones are really buried in deep and they can't even see them, they say, sure, I'll stick my hand in the jar. So then I think now they understand. Saw a donor yesterday. He said, I'm willing to take the risk. And he had a lot of risk factors. And he kept on saying, I'm willing to take the risk. And I had to say to him, I understand you're willing to take a risk, but the risk, how can you say you're willing to take the risk unless you actually know what the risk is? So my job is to give you the risk. And then it's our job to decide if we're willing to accept that risk. So I'm just going to pass over. This is a recommendation from a U.S. international working group, actually, about how to do this. And it's much in line with what I'm thinking, is that you got to decide what your threshold for risk is. And so this is your risk threshold. And if a candidate for donation is under your risk threshold, then you should then together you decide whether to go ahead. If it's over your risk threshold, you say, well, together, I don't care, we're not going to do it. So the job, though, is to come up with that number. And so there are some risks that come to an individual just because of who they are, their genes, their family history, and there's some stuff that happens in the environment which could increase their risk. And then if you donate, I said it stands to reason that there's going to be some increased risk, because when that second thing happens, when you get diabetes, some of those people are going to get diabetic kidney disease. If it's going to progress, let's say, over 10 years, to kidney failure, if you develop diabetes when you're 75, and if you have 2 kidneys, you'll die of old age and your kidneys won't be an issue, but now you only got 1, and you're going to bring that time horizon down, and now you're looking at kidney disease when you're older and ending up on dialysis. So how much is the multiplier? How much is it different from having 1 kidney to 2? And so this is a great first step. I think this is a similar group to the ones that Dori Segev and some of the people who were working with him, and Amit Garg in Ontario, who is who did some of the other donor work. This was in the New England Journal late last year or early this year, and basically we were talking about diabetes as a risk, high blood pressure as a risk, BMI as a risk, but we looked at them individually. This is composite. So you put it all together, and they came up with a model, and I'll show you, and this is online. So you go to transplantmodels.com, and you'll see this. This is what comes up. So there's a whole bunch of variables you can put into it. You put the age, the sex, the race, the EGFR, systolic blood pressure medications. It says no, 1, 2, and if it's more than 2, they expect you're not going to use the model because you're going to turn them down. You can put in any BMI. No diabetes or borderline diabetes. Again, they don't have diabetes because they expect that if you're diabetic, you're not going to use the model because they're not going to donate. You're an ACR. Now this is in U.S. units, and ours are basically divided by 10. So for ours to put it in the model, you'd multiply by 10. So if it's 0.2, it says it's 2. And smoker, non-smoker. Actually, that's not right. This is the lowest urine ACR so we're not going to accept donors who have any significant ACR. So just leave it at 4. Leave it at 4, and then smoker, non-smoker, quit smoking, and current smoker. So that 40-year-old woman has an incredibly low number for the risk of developing kidney failure in the next 15 years. That's if she gets up and walks out of your office. No donation, goes ahead and donates. And in her lifetime, because she's 40, there's still a fair number of years. The risk is higher than 0.4, and older people get more kidney disease, so their chances of getting kidney disease in the rest of her life is 0.3%. Now, they put question marks here, and that's where we need more information about, what do you multiply it by? So now she's a donor, she only has 1 kidney, what's the risk multiplier? So a very aggressive number might be 4 times. So I've been using 4 times. So I say to people, okay, so your lifetime risk now is 0.3, multiplied by 4, it's 1.2%. So when we're balancing that, we're having that discussion, I'm willing to take the risk. Well, the risk, I can now have a numeric for it, it's 1.2%. Where do I draw the line? It's going to be harder than that. We're still debating as a program, but I think we're working around the 3 to 5% number where we would say, well, that's something that we can live with, realizing that a donor will end up on dialysis, just like a donor somewhere in Canada actually died. So there will be a donor who ends up on dialysis. And actually, ironically, 2 days ago, we did a transplant of the second transplant that we've done on a previous living donor. One small fact is that we prioritize the previous living donors, and if I still want them to get a living donor transplant because we saw living donor transplants do better, but if they don't have a living donor, then we would prioritize them on the deceased list. So let's see how this works in another situation. So a situation where we would have used to say this is bad, this isn't such a good idea for you to donate, is when you're older, and this is an older man, he's 62, but he's got high blood pressure, and he's on blood pressure lowering medications. But because he's already 62, his lifetime risk isn't actually that much higher than that 40-year-old woman who looked perfect. And so so I think what this calculator will do is let us accept older people, but be more cautious with younger people, because this is a young guy. He's on blood pressure lowering medications. Because he's on a blood pressure lowering medication already at a young age, his lifetime risk before he walks, even if he walks out of your office, is 1.39%. You multiply that by 4, you're over 5, and I think most people would say that's too risky. Shows you how bad race is, and in Canada we don't have the Afro-American or Afro-Canadian, but we do have our Aboriginal population, and they're very high risk for kidney disease too. And so when I haven't known what to do with them, I've substituted, when it's been Aboriginal, I put in black, and to get some of these numbers. And you can see you can generate some pretty astounding numbers. But again, on the other hand, even a woman who is borderline diabetic on blood pressure lowering medication, doesn't even have the greatest GFR in the world, is only 80, because she's 65 and is healthy at this point, her lifetime risk is 0.5%. Multiply that 4, it's 2%. Still feels pretty, would you take a 2% risk to help your daughter? Like I said, I'm okay with it if you're okay with it, but the number one thing is you got to understand that. So now I'm putting 100 jelly beans in the jar and pulling out 4 of them and saying, are you willing to still put your hand in the jar? So this is just some ideas of how to use the model, and certainly smoking really pushes up the model. So there's some That's the second place where code whites happen. It's actually number 1, I think. 10C would be number 2. So current smoker, so smoking can really push up the model. Smoking and diabetes, that's bad news. And just showing how, a young black person who has any risk factor, like even smoking and everything, it's out of sight. So the model is helpful, I think, in being able to be black and white with donors. Those numbers were generated based on real data. And so, as kidney failure is not that common, even though high blood pressure and diabetes are incredibly common. Most people with high diabetes and blood pressure do not get kidney disease, do not get kidney failure. And what I say to every donor is you must. And if you can't do this or you won't do this, you can't do this because you're coming from a place where you don't have access to it, or you won't do it because you're just not that type of person that does that stuff, then you shouldn't be a donor. But you need to go once a year minimum for a checkup. You have to have your blood pressure tested. You have to have your creatinine measured to see what your GFR is. You have to do a urine test to make sure you don't have protein in your urine, and you have to make sure you don't have diabetes. All those are good, you're good to go. You're good to go for another year. The next year, blood pressure is a little bit high. blood sugar's a little bit high, you don't sit on it. You don't see let's go, you get proactive, you have to do whatever it takes to control those things. And if you do, I think, you can mitigate that risk. You're not going to end up on dialysis, I think, if at the first sign of trouble, unless you have some catastrophic thing, if it's from like a disease, which can be controlled, if you get on it early, then it's not likely to happen. So donor follow-up, donor maintenance of health is really important. So again, if somebody's 25 and already overweight and is sedentary and is a smoker and has a strong family history, GFR might be 120, everything might look good, but it's hard to modify all those things, and human nature isn't necessarily such so that maybe that person shouldn't be a donor. Other people will say, I'm highly motivated to donate, and the fact that I do donate is going to help me do those things. And, again, it's that discussion, but, people who you believe are, reliably going to do what it takes for donor follow-up, who are well-informed, if that number is like within your threshold, I think donation is the right thing. And so what I'm looking for today is to help you come, some way towards saying, that makes sense. That's good. The team can make a good assessment. My donors are getting, potential donors are getting information, and that's something that I really feel like my patients can benefit from, and I'm not doing them a disservice or their family or friends a disservice by promoting living donation. So now I'll stop and entertain some questions. Sure, there's questions. I take them from anywhere. Peggy has a question.
Just a question about the donor follow-up. Is it up to the donor to go and ensure they have this done through their GP or what?
So once a year, they get a letter from us reminding them that it's time. We send a letter to the GP as well. We receive the testing, but we don't actually physically see them unless there's a problem. I would say I don't see every result. All of the results come in, and I see the ones that are concerned. We either get in touch with the patients or the family doctor and say, hey, this GFR is a bit lower than we expected. We should keep an eye on this or whatever. But I say to patients, at the end of the day, it's your responsibility. We send you a letter, but I don't come to your house and say, okay, we're going to the lab now. It's time for your yearly test. So, so there, at the end of the day, it is the donor's responsibility to do that. And, I definitely impress that on them. Mike.
What are the age cutoffs for donation, and what are your absolute contraindications?
So Dr. Schachter asked about upper age limit for donation. It's a moving target. It definitely is a moving target, just like recipients. So the oldest donor we've used right now, I think, is 72, maybe 73, mid-70s. Not every 70-year-old is going to, you got good GFR, you're otherwise healthy. We had a 78-year-old frail woman who wanted to be a donor. Everything looked good, but we were, could she get through the surgery? Was her perioperative recovery going to be as smooth? So we sort of, but there would be way less 75-year-olds you would accept as 45-year-olds, just because of stuff happens. But if you're good at 75, you're probably okay. Absolute contraindications, high blood pressure on more than 2 drugs, diabetes, cancer, which could potentially be not so much of a donor factor, but could be transmitted through the donation. In some infectious diseases, cardiac disease, BMI over 40 for sure, but 35 would be a relative contraindication. So, pretty obvious stuff. Another question here.
Does a living donor get a priority if we do the transplant?
Yes. So we've done 2 transplants this year on previous living donors, both whom were prioritized and got them pretty quickly. So that's the only 2 we've ever done, to my knowledge, in BC. It's rare. One of the donors donated in Alberta. One donated here. So how did that happen? He actually was a donor a long time ago, and he didn't do the donor follow-up. He did it for a little while, and I actually was a little bit worried about him, and he came to I actually saw him as as a patient to try and, I'm not saying I could have prevented everything, but he was a terrible patient. He never came back for follow-up. He had high blood pressure, he didn't treat it, but then he had a whole bunch of other things happen to him. Which I think, would have happened whether he had 1 or 2 kidneys, but, he ended up on dialysis and, and I'm sure it happened more quickly. Anybody out there in the regions? Okay, another question here. So part of, there's it's a 4-part evaluation. Nurse, nephrologist, transplant surgeon, and social work. All of us, ask questions about drug use. Certainly, drug use versus misuse. I mean, certainly drug misuse would be a contraindication. An occasional user, occasional alcohol drinker, or even, soon to be legalized, an occasional pot smoker, we wouldn't view as a contraindication. But anybody who, in whom it was misuse and in whom it was having some negative effect on their life, or our prediction that it would have a negative effect on their life, we would not accept. Other questions? Doctor, he's going to throw something at me.
No, it's just Facebook friend.
Yeah.
So we're there?
I'm there. but I got to bring the whole team along with me. I'm not saying every Facebook friend would be okay, but if the basis of their meeting was on Facebook, or if they knew about it from Facebook, that to me wouldn't say, okay, that's a showstopper, we're not going to do it. I mean, we're going to assess the donor and do all of the things. This is what I think we should do. We're going to assess the donor and do all the things we do in any donor workup. And certainly, as people become further removed, I think, but maybe I'm being naive, I think as people become further removed and the relationship isn't as close, my index of suspicion that maybe they're not altruistic here, that there's some potential gain for them that we don't know about could be occurring. And if that's the case, that's A, it's illegal, but B, I think it's morally repugnant, and it's our job to make sure that that's not happening. So my index of suspicion might be higher, even though there's no reason why a brother couldn't be paying his brother, and I'll never know about it either. But so we're vigilant, but I wouldn't say out of the gate, no. Yes, sorry. So with living donation, HIV, I would never take a HIV positive donor, because they'd be on all sorts of medications which would potentially be hard on their kidneys and stuff like that. So that wouldn't be a safe thing to do. We could potentially do a Hep C to Hep C. If the situation was right, it would have to be somebody. The donor would have to be somebody who had been treated for Hep C and had cleared the virus and was totally healthy. And then there's still that theoretical risk of transmission through the donor kidney. But to a Hep C recipient, that would be a reason. That's not an unreasonable thing to do. Okay, if there's no more questions, I think we're just good for time, and it's time for a break. Thanks.